Thank you very much, and thanks very much to the organizers for the opportunity to share our data. I'm presenting on behalf of my large team. So unless you've been living under a very large, well-insulated, and media-free rock, you know as well as I do probably the details of the Mississippi baby, who is a case who received early antiretroviral therapy and went on to experience a 2-year viral remission after stopping treatment until an unfortunate recent viral rebound. This case has generated a lot of excitement in the field in that it raises the possibility of early antiretroviral therapy as an intervention to limit reservoir establishment and potentially enable viral remission. Triple antiretroviral therapy as post-exposure prophylaxis in neonates has been routine in several centers in Canada, including the Hospital for Sick Children in Toronto, the Children's Hospital of Eastern Ontario in Ottawa, and CHU Saint-Justin in Montreal. And so this has given us an opportunity to look at the impact of earlier antiretroviral therapy in that this is not something that will prevent all infections. And so we've effectively created a small cohort of patients who has been on treatment since birth. And so the objectives for this presentation are for this study were to investigate HIV reservoirs and peripheral blood of HIV-infected children with sustained virologic suppression following early initiation of therapy within the first 72 hours, with sustained virologic suppression defined as an absence of detectable virus in standard assays, subsequent to having achieved an initial undetectable viral load. We performed a retrospective review at our 3 centers of all children who were born to HIV-infected mothers who received triple therapy as prophylaxis within 72 hours of birth. And we went on to evaluate HIV reservoir, immune responses, and genetic characteristics of those infected children who experienced sustained virologic suppression. We had 136 children in our 3 centers who had received triple therapy at the time of this study, and 12, or 8.8%, unfortunately were infected with HIV. In utero infection was probable in at least 50%, in that 6 of them had a positive DNA PCR within the first 48 hours after birth. The timing for the other 6 is uncertain, and that testing was done after that point. There were 4 children who went on to have sustained virologic suppression, who I will describe in detail as cases 1 to 4. And the other 8 children did not achieve SVS. 6 of them never achieved it in infancy due to poor adherence. The other 2, however, initially suppressed for 2 to 3 years, but then experienced viral rebound after poor adherence. One of them, interestingly, had this happen during the course of our assessment, and so I will describe the outcomes for this patient as case 5. Cases 1 to 4 had suppression for 2 to 7 years at the time of our assessment, and all 4 of them remained on their original CART regimen of zidovudine, lamivudine, and nevirapine. This table describes maternal and infant characteristics of interest. You may notice that the maternal characteristics for cases 3 and 4 are the same, and that is because it is a case of twins. I'll point your attention to a few details. First, all 3 mothers had advanced HIV disease with low CD4 counts. All 4 infants were premature, ranging from 27 to 36 weeks gestation, and all 4 of them had positive DNA PCRs within the first 48 hours of life. This graph depicts the event postnatally, and this is the only child who had a viral load taken on the first day of life, and you'll note a reasonably low viral load of 1,890 copies. The child was initiated on therapy immediately, and you'll see that the viral load took approximately 6 months to suppress. The other 3 cases did not have a viral load taken on day 1 of life. However, the other 3 showed a second phase decline of viral load, unlike the first one who showed first and second phase decline of viral load. This table is our evaluation of the 4 children with respect to reservoir and genetic characteristics. All 4 had negative serology, negative CMI to GAG and NEF proteins, and undetectable viral loads down to a level of 1.5 copies per ml. None of them had any cell-associated proviral DNA detected, but all 4 of them had small amounts of cell-associated RNA detected, ranging from 19 to 130 copies per 1.5 micrograms of RNA. We performed 2 assays to look for replication competent virus. One was mitogen stimulation of CD4 T cells and quantitation of HAV RNA, and this was not detectable in any of the 4 infants. We also did quantitative co-culture, looking for replication competent virus in 3 of the 4 children, and 1 of them had a very small amount of replication competent virus detected at 0.1 infectious units per million CD4 cells. Genetic characterization of the children showed that all 4 of them were wild type for CCR5, but 3 of the 4 had what are considered protective genotypes with respect to HLA typing and HLA-B variation. Interestingly, the one child who had infectious or replication competent virus detected was the one who did not have protective genotypes. Case 5 had initiated an assessment while still suppressed. This child was 3 years old at the time of our initial assessment and also had negative serology, undetectable viral load, absent proviral DNA, small amount of cell-associated RNA like the others, but no infectious virus detected in mitogen-stimulated CD4 cells. This child also had protective genotypes with respect to HLA typing and HLA-B variations. This is a graph of this child's viral evolution, and the child started combination therapy on day 1 of life. However, he differed from the other children in that at about 3 weeks of age, the maternal genotype returned showing NNRTI resistance with K103 mutation, and so the regimen was changed to AZT3TC lopinavir. This child also differs from the others in that there were 2 very low level detection of viral replication with a viral load of 83 at approximately 110 days of age and 40 at the limit of detection at approximately 200 days of age. After this, the viral load remained suppressed up until age 3.5 years. At that time, the child was having significant difficulties with adherence. This is not uncommon at this age in that they become quite obstinate. And so rather than having them be on a regimen where they're only receiving half of their medications, a medication interruption was undertaken, and the child quickly developed a rebound of viral load. Within 2 weeks, the viral load went up to 7,000, and then within a few months went up to 100,000. CMI testing was done at approximately 2 months after interruption, which showed now CMI positive against GAG and NEF. Serology and DNA PCR also became positive, and the child was eventually restarted on therapy after interventions with the family. So, absence of detectable HIV DNA and absent or very low levels of replication competent virus in peripheral blood and lack of HIV-specific immune responses was demonstrated in this small subgroup of children initiated on combination therapy in the first 72 hours of life. And it provides further evidence that early combination therapy can greatly reduce HIV reservoir size. It would appear possible that genetic factors may also be playing a role in this ability to control HIV and have low reservoir size. And it is worth mentioning that the child with replication competent virus did not have these protective genotypic features. Our fifth case with rapid viral rebound after interruption of therapy, despite very limited reservoir size, demonstrates, as we all would have said before the Mississippi baby case, that early CART certainly will not be effective in all patients. However, multiple factors may have influenced the outcome in this patient in that they had baseline NNRTI resistance and were thus on a suboptimal initial regimen with nevirapine. And they also had a couple of low-level detectable viral loads after initial suppression. This information, along with the late relapse of viral replication in the Mississippi baby, underscore the need for a better understanding of the contributing factors to reservoir and viral control, including host and viral genetics, timing and completeness of initial viral suppression, and selection of components of therapy that will achieve these goals. So in conclusion, based on our study findings and other reports, early CART for HIV-infected infants clearly limits the size of viral reservoirs. We do need additional non-blood reservoir site investigations, although this will be difficult in this age group. And the clinical significance and benefit of early therapy beyond the ability to come off therapy remains to be seen. Accurate estimation of the size of reservoirs in children is significantly impacted by limitations of blood volume that we're allowed to take in comparison with adults. And when we compare the number of cells assessed for replication-competent virus in the adult studies, they are vastly higher than what we are able to do in children. And so this is one of our limitations. We are now conducting a prospective multi-center observational study, which we called EPIC-4, in Canada to try and determine the impact of early therapy compared to later therapy in HIV-infected children. So I'd like to acknowledge the children and their parents who agreed to participate in this study, which has been quite intensive for them, as well as the Canadian Institutes for Health Research, Canadian Association for AIDS Research, and the International AIDS Society for recent funding to conduct the cohort study I just described. Thank you very much.
Presentation is open for discussion. Yes.
Congratulations, Jason, for a wonderful presentation. I'm Dr. Naina, working with the PMTCT program in India. My question to you is, I wanted to find out regarding prophylaxis of CART that you're giving, what's the duration that you were looking at? That was not specified, so I just wanted to know, and also how we could use this for our cases which come in very late. We have this direct in labor cases which do come, and as of now we are giving nevirapine syrup for extended duration of 12 weeks, but we really haven't studied these cohorts and found out how many of them are positive. So I think it's very, very important that we take these lessons back home about combined therapy, combined prophylaxis. So I was very curious to find out regarding the duration that you had induced this as prophylaxis. Thank you.
Thanks very much for your question. Our practice in the 3 Canadian centers is to use nevirapine, 150 milligrams per meter squared once daily for the first 2 weeks, followed by twice daily for another 2 weeks, which is the dose recommended after 2 weeks of age, along with 6 weeks of zidovudine and lamivudine. In the event that there was a transmission, we did not want to incur or additionally incur NNRTI resistance if we had stopped, if we had continued the nevirapine longer. We presented some data at the Pediatric Symposium preceding IAS regarding the pharmacokinetics of this approach, and that study continues to be underway, but it appears to be safe in the context of having therapeutic drug monitoring. I believe there are also studies underway through P1115, which will look at another dosing schedule for nevirapine.
Next question.
Thank you, that's fascinating. Can you say a little bit more about EPIC-4? What is it? What are your endpoints? What's it sized for? And are you going to do treatment interruptions? Are you planning them?
Oh, thank you. EPIC-4 is a study spurred on by the fact that we have this opportunity with these cases to try and evaluate them in more detail, both in a cross-sectional manner which we've already done with these few cases, and also in a prospective manner. We'll be comparing them, this small subgroup, to other subgroups in Canadian centers across the country. All the Canadian pediatric HIV centers of size will be participating, and what we hope to do is compare reservoir size as well as other immune factors between children who start at that age versus within the first 3 days to 1 year of life versus an older age group. And also look at those who've been suppressed for many years as Dr. Persaud has done in the US Impact Network. Thank you.
Thank you. Any more question? There's one back, yes.
Yeah, that was a nice presentation. Elijah Painter from Yale University. Jason, I just wanted to clarify, probably I missed out on that. Did you confirm the K103 and mutation in case number 5?
Yes, that was, we had the maternal genotype come back at that point, and then the child's genotype came back later, but they were the same. Okay. So K103 was in both.
So no more questions? Yes, Pablo.
Congratulations for your work. I didn't quite see what was the time to undetectable viral load for those kids, because I think that is a very important thing on the children, that it is not only starting early, but also having undetectable viral load very early, and that was shown in the Mississippi baby, that was, I think, in 29 days or so. So what was the medium days of undetectable viral load on your cases?
Thank you, Pablo. The range of time to suppression for the 4 cases was about 2 months to 6 months, although none of them had a higher viral load than 2,000. The case 1 had a viral load at birth of 1,890, and the others had less than 1,000 at each subsequent measurement. So they had very low levels of viral replication, but took, I agree, longer to suppress than did the Mississippi baby. And that may well impact the outcome, and we are interested to see how that will play out.